Good afternoon. Welcome to part 3 of our Coming Together for the Cure series to promote breast health and awareness. My name is Umber Dickerson. I'm the director of the cancer program here at Parkland Hospital and Health System. We are so excited to have you join us today. We will be recording today's session and currently streaming live on our Facebook page. So if you missed any of the previous series or want to rewatch today's session, you'll be able to see the entire series on both Parkland's Facebook and YouTube accounts. We encourage you to submit any questions that you may have throughout the presentation on our WebEx chat function or on Parkland's Facebook page. We'll be answering your questions during the Q&A session at the end of today's events. Without further ado, let me present your panelists today. Our first panelist is Chandler Myers. Chandler is a certified genetic counselor who joined UT Southwestern genetics program last year. She received her master's degree from Northwestern University in Chicago with a degree in genetics counseling. Our next panelist is Dr. Jessica Poremka. Dr. Poremka is the medical director of Parkland's breast imaging and for radiology's quality assessment. She currently is the assistant professor at UT Southwestern for radiology, specializing in breast imaging. Dr. Poremka has a passion for saving lives through early detection and diagnosis of breast cancer by using a multimodality, multidisciplinary approach to provide excellent care focused on each individual woman. So starting now, we'll show you the slide deck that we will be presenting today. Before we get started, let me go through some of our guidelines for today. Upon joining, please mute yourself. The meeting will be recorded live and live streamed on Facebook at Parkland. All comments, questions should be typed in the WebEx chat function. Questions and comments will be monitored on Facebook. Kicking it off now to Chandler, who will be discussing screening and prevention for breast health.
Thank you, Umber. Hi, my name is Chandler. As she said, I'm going to be talking a little bit about genetic counseling and genetic testing and how those two things can factor into screening and prevention for breast health. So I'll start with a little bit of an overview about breast cancer. We know that about 1 in 8 or 12% of women will develop breast cancer in their lifetime. And when we consider the causes of that breast cancer, most of the time it's actually random. Most cancer is what we call sporadic, meaning we don't always know what causes it, though we know that there are certain environmental risks and lifestyle factors that can contribute to a person's breast cancer risk. So if you wouldn't mind putting those up. So age being one of them, family history of cancer, any hormone exposure, or whether a person smokes, their alcohol consumption, and their diet and weight. Even though most cancer is sporadic, we know that about 10% can be what we call hereditary cancer. And hereditary cancer is when there's a genetic mutation being passed down in the family that gives people a higher risk of cancer from the time that they're born. So when would we suspect hereditary cancer in a family? In a genetic counseling session, there would be a couple of key things a genetic counselor is looking for that might make them think a person is more likely to have a hereditary form of cancer. The first of those things is going to be a young age of diagnosis. So anybody that's had cancer under the age of 50 would be considered a young age of diagnosis. We're also looking for multiple generations of cancer in a family, cancer in 3 or more family members on the same side of the family, any person that's had multiple different cancers or bilateral cancer, rare cancers like ovarian or breast cancer in a man, and then even patterns of cancer. So any family where there's a breast, an ovarian, a prostate, and a pancreatic cancer might indicate a pattern. We know that sometimes Ashkenazi Jewish ancestry can be associated with hereditary cancer when there's a family history. And then also if there's a known mutation in the family, we might be suspicious of a cancer being hereditary. So why would we want to know if a cancer is hereditary? Like I mentioned earlier, breast cancer can be hereditary up to 10% of the time. And if we know that there's hereditary cancer in the family, we can do a better job screening a person for cancer, knowing that they're high risk. So we could get them more screening at an earlier age. We might offer them risk-reducing surgeries, They could be aware of their risk and change their own behavior to reduce those environmental components of cancer risk. It's also important information for family members to know so they can take the same steps. And if a person already has cancer and finds out that it's hereditary, there might be other options for treatment and for targeted therapies for that cancer. Now I'll talk a little bit about BRCA or BRCA. This is a common pair of genes that a lot of people have heard of, in part because Angelina Jolie is a carrier of BRCA1. She has a mutation in that gene. And because of her increased risk for breast cancer, she underwent a prophylactic bilateral mastectomy in around 2013, which is where she had both of her breasts removed as a means of reducing her risk for breast cancer. So these two BRCA genes are the most common cause of hereditary breast and ovarian cancer, which is often why they get discussed so frequently in genetics. BRCA1 and 2 both confer a significantly higher risk for breast cancer. So with a BRCA1 mutation, a person can have a breast cancer risk of up to 65% in their lifetime, for BRCA2 up to 49%. And there's also an increased risk of developing a second breast cancer in a lifetime. So even if a woman is diagnosed with breast cancer already, it could be important to know if she has one of these two genetic mutations so that we could better protect her from getting a second breast cancer later in life. As far as how screening changes when a person has an identified genetic mutation, I'll give a brief overview, but Dr. Poremka can give you many more details about this. So if we think about a person who does not have a genetic mutation, no family history of breast cancer, they would probably start giving themselves breast exams at around age 20 and then mammograms yearly at around age 40. For someone who's higher risk, maybe they do have an identified genetic mutation or an extensive family history of breast cancer, they might consider getting yearly MRIs at 25 and mammograms at around 30. Outside of screening, there are other options women could take to reduce their risk for breast cancer if they know they're at a higher risk. Those first couple of options are surgical choices. So like I mentioned with Angelina Jolie, there's the option of a prophylactic mastectomy, where you have your breast removed. This can reduce risk of breast cancer by up to 95%. You could also have your ovaries removed with a prophylactic oophorectomy. And not only does this reduce the risk of ovarian cancer, but it also significantly can reduce the risk of breast cancer, because we know that some of the hormones produced by the ovaries can contribute to breast cancer risk. There's also options of chemo prevention, so drug therapies that a person could take. Tamoxifen is an example of one of those, and if taken for 5 years or more, it can reduce breast cancer risk for up to 50%. There's also factors like diet and exercise that a person can control to help reduce their own risk if they know they're at a higher risk for breast cancer. With those BRCA genes, it's important to note that breast cancer is not the only risk that comes along with one of the genetic mutations in those. There's also an increased risk for ovarian cancer, BRCA1 up to 40%, BRCA2 up to 18%. There's a risk for pancreatic cancer, melanoma, prostate cancer in men, and male breast cancer. So though it may seem like that female breast cancer is the most common cancer associated with BRCA, men in the family, it would be important for them to get tested too if there's a known mutation. As far as what genetic testing has looked like over the past 10 years, in 2008, the BRCA1 and 2 genes were most of what we understood about hereditary breast cancer. So many physicians and genetic counselors were really only offering testing for those 2 genes. Sometimes they would add on the TP53 or PTEN genes, which are also known to have a pretty significant risk of breast cancer, but it was pretty small selection for genes that could be tested back then. In 2020, we can offer a lot more testing. Panels are often an option genetic counselors will offer patients that cover many different genes, genes associated with a number of different cancers. These can be tailored to adjust to a person's family history. They could get a big test that covers most everything if they want all the information. So we have a lot more options in terms of how much genetic information we can get from testing in 2020. This is just a screenshot of the National Comprehensive Cancer Network guidelines for who should be evaluated for breast and ovarian cancer in a hereditary sense. I'm not going to go through all of these, but just to give you sort of a taste of what the guidelines are looking for. It's based on how many people in the family have had cancer, what types of cancer have been in the family, and ages of diagnosis of those cancer. And many insurance companies will use these guidelines to determine whether they're going to cover genetic testing or genetic counseling for any person. As far as what genetic counseling will look like, if you made an appointment, the genetic counselor would ask you lots of questions about your personal history of cancer, or if you didn't have cancer, then your personal cancer screening history, colonoscopies, mammograms, things like that. And then they would ask about the family history, anyone in the family who's had cancer, to try to get an idea of how concerned we should be that the cancer could be hereditary. They counsel patients about genetics, what it would mean if we found a genetic mutation, and next steps beyond that. They would talk about the risks, benefits, and limitations of genetic testing. The sample is usually either a blood draw, or you could do a saliva sample and just spit in a tube. The results take around 2 to 3 weeks to get back, and the genetic counselor will walk through the results with you, provide any necessary next steps like referral to other cancer screening, letters for any family members that would like to be tested, and anything else that comes with either a positive or negative test result. So now I'll address some frequently asked questions about genetic testing. The first is, will my insurance cover counseling and testing? And the answer is, if those NCCN guidelines that I mentioned are met, then usually most insurance companies will cover the counseling and testing. I've heard genetic testing is so expensive, I couldn't afford it if my insurance doesn't cover the cost. And it's true that genetic testing in the past has been expensive, but actually currently many labs offer a $250 out-of-pocket price. If a person wanted to not go through insurance at all, they could pay $250 and get that genetic testing. I've already had cancer. What else can genetic testing tell me? Like I mentioned earlier, many of the genetic mutations we know of cause more than just breast cancer risk. They can cause ovarian cancer risk. And even for genes that don't cause breast cancer risk, there can be multiple cancers associated. It could also be important information to have for family members if they haven't had cancer. If we test a person with cancer, they have a genetic mutation, we might want to test their kids, their siblings, their parents, just so everybody can be better screened for cancer in the future. And if you have cancer and you find a genetic mutation, it also might alter surgical choices, treatment options. And finally, will my insurance company or employer use genetic information against me? And the answer is they can't, because of a law called GINA that actually protects you from discrimination based on genetic testing. This law basically says that your employer and your health insurance can't use genetic testing results to deny you coverage or employment. At UT Southwestern, we have cancer genetics clinics both in Dallas and Fort Worth. You don't need a doctor note to get a referral. You can certainly give us a call. The scheduling number is below, and we also do telehealth appointments in case you would feel more comfortable not leaving your home with everything going on. And then the next slide will be my email in case anybody has any questions for me. And again, that number for scheduling.
Thank you, Chandler, for that excellent presentation. We will be holding all questions to the end. Now we'll be moving to Dr. Jessica Poremka, who will be discussing breast cancer screening. Thank you, Jessica. Oh, please, Dr. Poremka, you are muted. Okay,
All right.
great.
Hi, good afternoon. Thank you for the introduction, Umber, and for the opportunity to talk about breast cancer screening. As Umber already said, my name is Jessica Poremka, and this is my passion. All right, so let's get started. I know that Chandler already presented some of these numbers, but I do want to emphasize their importance. Okay, so breast cancer is the most common cancer diagnosed in women. As Chandler said earlier, 1 in 8 women, or stated a little bit differently, 12 to 13%, will be diagnosed with breast cancer during her lifetime. There are approximately 3.5 million women living with breast cancer. For 2019 to 2020, more than 331,000 new cases are anticipated. And so breast cancer accounts for about 30% of all new cancer cases in women. Okay, so breast cancer is the second leading cause of cancer deaths among women. there are about 41,000 women are expected to die from breast cancer this year. And as we said earlier, about 3.5 million women are living with breast cancer. And this is a graph. So it's basically the death rate per 100,000 women for cancer deaths in the female population. You can see that breast cancer is the dark blue line, and it has actually sort of trending downward, but it still remains the second leading cause of cancer death. Go to the next slide. Okay, so a question that I've been asked before is whether mammography has reduced breast cancer deaths, and the answer is absolutely yes. We know that better outcomes are directly linked to breast cancer screening. Early detection results in improved outcomes and fewer deaths from breast cancer. So since 1989, hundreds of thousands of lives have been saved by the use of screening mammography and new developments in breast cancer treatment. So this graph shows prior to the widespread availability of screening mammography, the breast cancer death rate was essentially constant. You can see that the US breast cancer death rate in women prior to 1989 was unchanged for the previous 50 years. You can see that's a flat line. And then once mammography became more widespread in the 1980s, breast cancer death rate actually dropped by 42%. And when you look at breast cancer deaths in men who have the same treatment as women but are not screened, their breast cancer death rates have not declined. Go to the next slide. Okay, so let's talk about the benefits of screening mammography. So we talked about about 40% drop in breast cancer death rates. However, the benefits of screening amount to more than just the mortality reduction. So although this is an extremely important benefit, other benefits of being screened include less extensive surgery for screening detected cancers and less toxic chemotherapy for screening detected cancers. Chemotherapy is more effective for screened women, and this is also extremely important. So in a landmark study, Tabar and colleagues published in November 2018, the interaction between screening and chemotherapy. So some people have tried to argue that chemotherapy has improved so much that we don't need to screen, but this is simply untrue. Chemotherapy has definitely gotten better over the years, but it is most effective when tumors are smaller, and that's usually what screening detected tumors are. They're typically smaller because they're detected earlier before they become masses that you can feel, or before women develop symptoms like nipple discharge and things like that. So in Tabar's study, it covered nearly 6 decades of follow-up. All women had either 10 or 20 years of follow-up. This is a really, really long time, which gives much more credibility to the results. So using the same available treatments, women who were screened had 60% lower mortality at 10 years of follow-up than women who were unscreened, and 47% lower mortality at 20 years of follow-up compared to unscreened women. So this shows that chemotherapy is much, much more effective in women whose tumors are found by screening and found early. Okay, so another question that I get asked is, do I need a mammogram if no one in my family has ever had breast cancer before? And Chandler actually answered this question. The answer is yes. So more than 75% of women who develop breast cancer have no family history of breast cancer. There are a lot of different factors that go into it that are medical, hereditary, and lifestyle that Chandler also talked about. Age is one, younger age at menarche, older age at menopause, obesity, genetics, chest radiation for lymphoma treatment. All of those things can contribute to a person's risk, and they may not have had a prior family member with breast cancer. Next slide, please. Okay, all right, so what should we be doing? Well, all women aged 25 to 30 years and older should have a formal risk assessment for breast cancer. The American College of Surgeons recommends formal risk assessment for 25 years and older, and the American College of Radiology recommends formal risk assessment by age 30 years. And so it's actually very important to sort of know your risk, even in younger women. And so the next is women with average risk of breast cancer should start annual screening mammograms at age 40. And finally, women with higher than average risk of breast cancer should start annual screening mammograms at an earlier age with possibly supplemental screening. Okay, so why should we start screening at age 40? Well, breast cancer is a big problem for women in their 40s. 1 in 6 breast cancers are found in women ages 40 to 49, and women in their 40s tend to develop more aggressive breast cancers. Annual screening starting at age 40 saves the most lives and the most life years. And this is, based on randomized controlled trials that prove screening mammography saves lives for women ages 40 to 74. It's based on decades of evidence, all societies, including the American Cancer Society, the Society of Breast Imaging, the American College of Radiology, the American College of Surgeons, the American College of Obstetrics and Gynecologists, all recommend, all basically acknowledge that the most lives are saved and the most life years are gained when screening begins at age 40 and is performed every year. In fact, if you look at computer models and data from the National Cancer Institute's Cancer Intervention Surveillance Network, if women now in their 30s were to delay screening until age 50 and then participate only every 2 years, as many as 100,000 lives would be lost that could have been saved by annual screening beginning at the age of 40. And there really is no medical evidence or physiologic change, such as menopause, to support screening beginning at age 50 instead of 40. The cancer rate increases gradually as a woman ages, and it's only slightly more women diagnosed in their 50s compared to their 40s. Okay, so there have been some conflicting and confusing guidelines. The American Cancer Society has a set of guidelines, and the U.S. Preventative Services Task Force has a different set of guidelines. The USPSTF used limited and older data that underestimates the mortality reduction gained from screening mammography. And I said previously, all of them acknowledge that screening mammography does reduce mortality in women 40 to 74, and that screening every year starting at age 40 would save the most lives. However, the American Cancer Society and USPSTF sort of refer to the harms outweighing the benefits of screening. And I think it's really important to understand the woman's point of view. So, for annual screening starting at age 40, the CISNET models estimated that 1 life year would be saved for each benign biopsy experience. And you don't really need a survey to conclude that almost all women would be willing to undergo a benign biopsy to extend their life by at least 1 year. And the next slide. Okay, so this is a comparison of screening recommendation outcomes, and this is based on the CISNET models from the National Cancer Institute. So the first line is the American College of Radiology, Society of Breast Imaging, and the National Comprehensive Cancer Network guidelines. And we all recommend yearly, beginning at age 40, going through age 84. So the reduction in risk of dying of breast cancer is 40%. The number of lives that would be saved per 100,000 women is 1,190, and the number of life years gained is 18,900. If you move to the second line, that's the American Cancer Society recommendations. They recommend yearly screening beginning at age 45 through age 54, and then moving to every other year starting at age 55 to 79. Their calculated risk reduction of dying from breast cancer is about 31%, and the number of women whose lives would be saved is about 925, with the number of life years gained about 14,900. Finally, if you go to the very last line, so this is the US PSTF guidelines. Every other year, they recommend screening beginning at age 50 and ending at 74. The reduction in risk of dying from breast cancer is about 23%. The number of women whose lives would be saved is about 695. And the number of life years gained is about 11,000. If you look at the percentages that are in parentheses, these percentage differences are the percentage increase in the number of life years gained, comparing it to the USPSTF guidelines of screening every other year starting at age 50. This is actually a very big increase. We go to the next slide. I've also been asked about average risk and increased risk, and this is something that Chandler also talked about. So again, at average risk women, we recommend screening mammography every year, beginning at age 40. However, there are some women who have a higher chance of getting breast cancer, and some of the factors that may contribute to this are certain genetic mutations, a strong family history, although I do again want to emphasize that most women who develop breast cancer will have no breast cancer in their family. Prior chest radiation for Hodgkin's lymphoma, prior breast biopsies with high-risk lesions. And so these are some of the screening guidelines for high-risk women. If a woman has a known genetic mutation, and Chandler had talked about the BRCA mutations, or they have a lifetime risk of greater than or equal to 20% of developing breast cancer, we do recommend annual mammography starting at age 30, and then annual MRI, breast MRI, starting at age 25 to 30. In terms of breast cancer history and dense breasts at any age or breast cancer diagnosed less than 50 years, we recommend annual mammography starting at the time of diagnosis and annual MRI starting at the time of diagnosis as well. For the chest radiation history that we had talked about before age 30, we recommend annual mammography starting at age 25 or 8 years after the therapy, whichever is later, and then also annual breast MRI starting at age 25 or 30. And then this history of ADH, ALH, and LCIS, that's the high-risk lesions that I was talking about earlier. And we do recommend annual mammography starting at the time of diagnosis. And then you can consider MRI, but it's not a hard recommendation. Okay, so I've actually been asked this by several family members and friends. Should I still get a mammogram this year, given the COVID-19 pandemic? And the answer is yes. So unfortunately, breast cancer doesn't stop even for a global pandemic, and mammography screenings cannot afford to stop either. So mammography still saves lives even during a pandemic. And is it safe to get a mammogram? Absolutely. We have many safety protocols in place, including temperature checks, screening questionnaires, masking, social distancing, hand hygiene, wiping down surfaces. Not only are we social distancing, but we also have changes in our scheduling template that have reduced the number of patients that are going to be waiting for an exam at any one time. Your risk of exposure is low for imaging, and your radiologist and your breast imager, we're always concerned about patient safety and providing the safest exam possible. So what else is Parkland Breast Imaging doing? Well, we're trying to empower women with knowledge. We are increasing access to screening mammograms. We take self-referrals. Our mammograms are low cost if you qualify. We do accept patients with insurance. We're also trying to facilitate follow-up of abnormal mammography results to minimize post-diagnosis time to treatment. We have patient navigators at our center to help schedule timely follow-up imaging and biopsies. And these are the different places where you can get a screening mammogram. We have our Parkland Comprehensive Breast Imaging Center. It's on Maple Avenue, and that is a breast imaging center of excellence. We also offer screening at Southeast Dallas Health Center, and we have mobile mammography services that do go out to the Parkland clinics and also perform weekend outreaches. So you can come to any of those sites for your screening mammogram. Here's one of our events that's coming up, and in all of our flyers, we want people to know that everyone is masked. We have less people on the van. We'll have less people waiting. Everyone is socially distanced, and there's cleaning between every patient. Thank you.
Thank you, Dr. Poremka, for that wonderful presentation. We do have some questions from the audience. The first question is, I know I need a mammogram, but I've heard older family members joke about it and talk about it hurting. How painful is it?
So it's not comfortable. It's uncomfortable, but it's about, I would say, 5 minutes of discomfort for the trade-off of early detection and potentially saving your life. We know a lot of breast cancer survivors that have said that mammography has saved their life, and so I would think about it as, it's not the most fun thing to do, but it's a little bit uncomfortable, but I think it's a very important thing to do.
Thank you. How do I decide if I should be tested for BRCA1 and 2? Is there anything that would indicate that I should have that?
I would say, based on how much you know about the cancer in your family history, if anything I talked about sounded like something that could apply to your family, or sometimes people will Google stories about other families that have been tested for BRCA1 and 2. But really the best way you could know is if you just make an appointment with a genetic counselor. They can absolutely talk you through what your risk might be of having one of those mutations, whether genetic testing is really a good option for you, and any other questions you might have about coverage, other genes that could be found, other family history.
And the last one is something that, Chandler, you did touch on earlier, but can genetic results be used against you for life insurance or disability coverage?
It's a great question. And actually, yes, but the situation for that would be if you were going to apply for a new life insurance policy, and let's say you had gotten genetic testing, you have a genetic mutation, the life insurance company would be able to ask for that genetic testing report, as would disability insurance. So that GINA law that I mentioned does not cover disability insurance, long-term insurance, or life insurance.
Thank you. If you have any additional questions, please feel free to post it on Facebook or the WebEx chat function, and we will get back to you after the event. We will be sharing some information about the next upcoming events throughout the week. We do have a presentation tomorrow, which is Facts About Breast Cancer, tomorrow at October 22nd from 4 to 5:15 p.m. And also a Breast Cancer Awareness Symposium on Saturday, October 24th from 10 a.m. to 12:30 p.m. Please register at parklandctc.eventbrite.com. Thank you guys very much for today, and look forward to hearing from you guys in the future.
Thank you.